shortly. The proceeding will start 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 shortly.
Order! And can we welcome you all for our first session into problem drug use in Scotland, and we're looking forward to discussing these issues with you. Just for our record, who you are, who you represent, and anything by way of a short, with an emphasis on short introductory statement, because we have lots of questions to get through, so we want to get through as much as we possibly can. We'll start with you, Dr. Tweed.
So my name's Emily Tweed. I'm a clinical lecturer in public health and honorary specialty registrar. I'm based at the MRC CSO Social and Public Health Sciences Unit at the University of Glasgow. I'm a public health doctor by background, and I've previously been involved in projects looking at the health needs of people who inject drugs in public places in Glasgow city centre, and on the reasons for an increase in drug-related deaths among women in Scotland in recent years.
Tessa Matheson.
Hi, so I'm Professor Catriona Matheson. I am Professor of Substance Use at the University of Stirling, which is a relatively new appointment. Before that, I've worked at the University of Aberdeen for 20 plus years, researching drug use and services for drug users, health service response. So my background is originally as a pharmacist, but also in public health and in health services research.
Thank you. Dr. Parks.
Good afternoon, my name is Dr. Tessa Parks. I work at the University of Stirling. I've got about 20 years of experience in doing social services, social health research. I've worked as well as a service provider. I've worked in England as well as Scotland and Canada as well. I think it's important to say that I'll speak from the academic evidence, but I'll also be informed by service provision in the different roles that I've had. Thanks for inviting me today.
Grateful. Dr. McAuley.
Yeah, my name's Sandra Mccauley. I'm a Senior Research Fellow at Glasgow Caledonian University and Principal Scientist at Health Protection Scotland. My work mainly involves people who inject drugs and the harms related to injecting drugs in Scotland, particularly in relation to bloodborne virus and overdose. I've worked in the field locally and nationally for over 15 years now, and delighted to be welcomed to this committee.
Good. Well, thank you ever so much for being so helpful and concise with your opening remarks. Just to get things started, and perhaps just to be of help to the committee, could you possibly tell us what, in your view, problem drug use is, and also with that, in your response, just how badly it does impact and affect Scotland? And we'll start in the order I think we opened with, so we'll start with you first, Dr. Tweed.
Of course. So I think it's important to make the distinction between perhaps a quite narrow technical definition of problem drug use, which is often used, and the broader sense in which the committee might be interested in. The technical definition is the one used in official statistics to estimate how common problem drug use is in Scotland, and that focuses on problem use of opioids and benzodiazepines. But of course there is a broader issue about problem drug use which encompasses other drugs as well. And I think it's important that the committee is making that distinction between problem drug use and any use, because the vast majority of people who use drugs will do so for a short time without any harms. But really the focus, I think, of our work and our discussions today should be those people who experience problems from it. I don't know if anyone else wants to come in on the kind of definitional issues.
Help us out here, Dr. McAuley.
Yeah, I mean, I think Emily's captured that nicely. We very much focus on the problem side of things because we feel as that's the area we can make the most gain from policy and practice change. There's a disproportionate amount of harm suffered by the individuals who engage in problem drug use in comparison to the wider population who maybe be using drugs but not reaching that levels of harm, and that is demonstrated in the epidemic levels of drug-related death we have in Scotland and other drug-related harms that are very visible, not just to the population but in the statistics and the evidence that is clear.
Come straight to drug-related death. We'll come to you, Professor Matheson, and maybe you could help us by explaining, in your view, why you think there is a particular issue in Scotland. We've seen all the headline figures recently, the expected over 1,000 deaths in 2018, the 2.5 times the level of the rest of the UK. What is it that's going on in Scotland in your view about why this is happening here?
Aspects to that. So our rise in drug-related deaths, there's several strands to it. One, we do have an ageing cohort of drug users who started drug use in probably the 80s, late 80s, and who are now in their kind of middle age, but they are ageing prematurely. I know this was maybe something we would have covered later, but it's very relevant to this point. So they are ageing prematurely, so they have multiple comorbidities, so other health problems and, importantly, mental health problems as well. And what we did, we asked about mental health, we asked about all health, mental and physical, and mental health support came out as the most important issue for people, and 95% of the drug users we interviewed who were over 35 mentioned that they felt they suffered from that. So we have this cohort, they also suffer from premature, normal ageing conditions such as respiratory disease, cardiovascular disease. So they're physically more vulnerable and they're mentally more vulnerable. We have other particular issues in Scotland around benzodiazepine use, which has come to the fore quite recently in the last 3 or 4 years. And benzodiazepines, when you throw them into the mix of other drugs like opiates and alcohol, it becomes a kind of lethal concoction, because you get respiratory depression, which you do from opiates, but with benzodiazepines it compounds that effect. So we have all of those things. We also have issues around social support, about trauma. There are many other aspects to it, but it might be one of my other colleagues might want to come in and
struck us in the written evidence was just the focus that we had in repeated submissions about childhood trauma as being a push factor when it comes to this, whether that's to do with emotional neglect or abuse. Is there any reason why that should be a bit more prevalent in Scotland and why we've got this? Because I'm not hearing any sort of clear detail about why there is a specific difficulty and issue that we have in Scotland. Is anybody here who could help with that one? Yes, please.
So you're absolutely right that what we often call generally adverse childhood experiences are a risk factor for later problem drug use. So that might include neglect, physical, sexual, emotional abuse, but also things like having a parent in prison, having a parent with mental health problems, domestic violence within the home. And these adverse childhood experiences, you might hear them called ACEs, have really risen up the agenda in recent years. There's a lot of awareness of them. And certainly they're much, much more common among people who experience problem drug use than among the general rest of the population. We certainly identified it as a factor in the work that we did looking at women who experience drug-related deaths. In terms of whether it's a particular problem in Scotland, there was actually a piece of work done by colleagues in Glasgow, Michael Smith and colleagues recently, that looked at whether it was more common in Glasgow and the west of central Scotland and Scotland in general, and whether that could contribute to, for instance, the excess mortality that we see in Scotland. And they found that some forms of adverse childhood experiences did appear to be more common, such as having a parent in prison and having a parent with substance use, experience of domestic violence within the home. But other forms, so particularly based on self-reports and surveys, weren't any higher. So they concluded there was a bit of a mixed picture in terms of what the evidence says about whether adverse childhood experience is more common in Scotland. What we do know that's really important about adverse childhood experiences is to set them in the wider context in terms of the social processes and drivers. So they're very closely linked with poverty, deprivation and inequality. And I think it's important that we see poverty and deprivation themselves as adversity, particularly in childhood, and we don't forget that context.
Before we move on to some of the other questions that we've got, and first I've got Tommy Shepherd and then Ross Thompson. Tommy.
Yeah, I just wondered if anybody could hazard a guess at what proportion of use of illegal drugs ends up being problematic. And my interest in asking this is to try and get some sort of handle on, for want of a better word, the scale of the market in illicit drugs. Is it 1%, 10%? I don't know. I mean, personally, I know an awful lot of people over the years who have used drugs which are illegal, and they've done so without any harm to themselves or others, and it's not been a problem. But what is the scale of the problem? And also, if you could suggest why is it because of of other factors like the social that we'll come on to, like the ACEs or social factors? Is it because of that some people develop a problem and others don't? Or is there something else at play in terms of who will develop problematic use?
So to take your first question about the size and scale of the problem, so prevalence of problem drug use, there's studies conducted every few years on this using scientific methods to estimate the size of the population. The prevalence of problem drug use in Scotland is currently 1.6%, so that equates to roughly 60,000 people under that kind of tight definition of problem drug use, problematically using opioids and or benzodiazepines. And that prevalence rate hasn't changed much over the years. It's remained largely stable.
That's 1.6% of the population?
Yes.
What percentages of that of all people who use drugs?
So that's not, traditionally that's not the way it's estimated. The estimate, we don't follow people up in cohorts in terms of everybody who's tried drugs, just because of the challenges in actually ascertaining everybody who's ever tried and who goes on to problematic use. We take quite a difficult kind of cohort longitudinal study to do that. What we tend to estimate is the people who are at most at risk, and these are the people who are the ones contributing most to harm levels, health services, criminal justice services and the like. Now, the key point there is, and it links in with what Emily has just said about whether adverse childhood experiences are more prevalent in Scotland than they are in other parts of the UK or indeed Europe. They are prevalent in people who experience problematic drug use, and Scotland is known to have very high rates of problematic drug use, or rates of problematic drug use are much higher than they are in other parts of the UK or even in Europe. That's why we see significant levels of harm, because it correlates very strongly. If you've got large populations of people using problematic drugs, you'll have large numbers of drug-related deaths, drug-related infections, etc., etc. So there's a very direct correlation there.
Thank you. Thompson. Sorry, well, Dr. Tweed was wanting to come in with a few
Very briefly, one of your subsequent questions was about, I suppose, the relationship between problem use and use more generally, and whether social factors play any role in that. So we do see a social gradient in both use in general and problem drug use, but the gradient is much steeper for problem drug use and drug-related harms. So the inequalities are greater when it comes to problem drug use, and that's partly I think about the forces behind that in terms of limited opportunities, sense of disempowerment, exclusion, but also about what we might call kind of recovery capital, or things which support people. So things like housing, good work, being able to navigate the system. So I think those are some of the factors that for more advantaged people mean that their use might not translate or subsequently develop into problem use or into harms.
Ross.
Thank you very much, Chair. And actually, it's a very similar sort of question I was going to ask to what Mr Shepherd asked, which was in the opening remarks. You mentioned the focus being on the problematic drug users, but across the wider population, there are those who use without harm. So, what is your definition of what a problematic drug user is? Just so I'm sort of clear in my head what we're actually talking about. And in terms of those that you do deal with who are problematic users, in what proportion would start off as somebody who took it infrequently, started off as I take it without harm, and then maybe becomes a bit more habitual, then becomes problematic. So to get an idea of, I know that's not for everyone, but what sort of proportion would you say start off as maybe take it at a party on a night out, and then it becomes something which is a bit more problematic?
It's a really difficult question to answer. I think you're asking the same question.
Sorry. Could you also speak up just a little bit? It's a big room.
So that sounds like an easy question, or I could see you would want the answer to that, but it's actually a very difficult question to answer, because for the reasons Andy explained, we don't follow people up at the point they occasionally use drugs. So the other source of information we have are population surveys, where you just do a snapshot of the population and you say, have you used any of these drugs? And things like cannabis always come out about the highest. But what we can't do is link that to how many people develop problematic drug use very easily, because it's different substances and different patterns of use. So that progression is very difficult to express in a percentage, unless anybody's come across any research. But I think it's something that has been a challenge in this field.
So again, a very simple question, but it's just for someone who's problematic. Would you determine that as someone who genuinely cannot sort of function without substance or
it's a very tight. Obviously, we use this definition because it's helpful to have sometimes a number to work with when you're planning services or planning research in that way. But obviously, our work goes beyond that. It doesn't just focus on everybody who's problematic using opioids and or benzodiazepines. Cocaine has seen a major shift in Scotland, for example, over the last couple of years. And there's large bodies of work that we're all involved in, focusing particularly on the group in Glasgow who are injecting cocaine at the moment. Those definitions are used specifically for a purpose, and it's very difficult, as Catriona says, to measure everyone at the point of starting and how they transition in that point. It's purposeful to have a definition that's as tightly framed as that, but it is also prudent to review that definition over time to make sure it's capturing changing trends in the population.
Very last supplement, because when we're talking about those factors behind drug use and particularly deprivation and poverty, some of the things I've been reading about recently, which is of interest, I don't think there's a question on this later on, but was just about sort of the middle class drug use. Is that a growing problem in Scotland as well? So it's not just those who experience deprivation or poverty, but you've now got an area where in middle classes it's becoming a bit of a growing issue where people use it, I don't know, in recreational terms. I don't know. It's something I've read a bit about.
They've highlighted the limitations of the data that we have in relation to drug use. It's a very difficult problem to gather evidence on, as I'm sure we'll come back to again. I mean, what we do see from things like the Scottish Crime and Justice Survey, which is done intermittently, is we do see this clear social gradient in terms of use and an even steeper social gradient in terms of harms. So I'm not aware of any evidence that points towards a growing problem among the middle classes. No.
Hugh.
How can we measure this then? I mean, it's all walks of life. I mean, we're making it a social thing as if it's the bottom of the pile, but it goes right through every walk of life. So why aren't we using court figures, for instance?
I mean, actually, ironically, Scotland has some of the best drug data anywhere in Europe, if not the world. Our surveillance data is very good. It does tend to focus on the more harmful aspects of drug use, though, because that's where a lot of these people present, whether it's at hospitals, whether it's in prisons, police cells, social work reports, and it's a lot of these sources that are used to triangulate to get an idea of the size of these populations. Similarly, we're involved in studies that go out every 2 years into needle and syringe exchanges and interview people in there to get an ascertainment of that side of the population as well. Whereas to look at the whole population of people using it, you'd be thinking more of a census type study, but you'd be looking at a large chunk of the population who are using drugs in a way that's not going to get them into any difficulty, whether it's a harm related to health or related to criminal justice. That's why we tend to focus on the people who are experiencing the most problem aspects of drug use.
Hopefully maybe through this inquiry it will come out that we'll all get better figures, but 1.6 seems very low for a big problem in Scotland with drugs. So maybe during the process we'll get there.
Again, your point about all walks of life, and it's true, so drug use and problem drug use does affect people from all walks of life, but we see it's about the preponderance. So the percentage, that prevalence will be higher among people from more deprived areas. That's not to say that people from the middle classes or the most advantaged groups won't have problems with drug use. It's just about the preponderance, really, and about that distribution. The harms and prevalence of problem drug use will be higher among people from less advantaged backgrounds.
Okay, please.
Thanks very much. I can also make the point that it's more challenging for people who experience problem drug use if they're criminalised in the criminal justice system to actually manage to pull out the recovery capital or the social resources to try to mitigate some of the harms. So while drug use is a phenomenon across all social classes, all genders and across all ages, the harms, and particularly the risky harms that the panel have just spoken about, is gradated, and some of the protective factors that we know through, for example, being brought up in a secure and safe house and family environment, those protective factors are not always in place for people who end up in risky situations through their drug use. So as well as childhood abuse that Emily's just talked to, I wanted to also mention that adult abuse is also very prevalent for people that end up with both mental health problems, which I know the committee's interested in, and domestic violence and domestic abuse. So we know that commonly intergenerational effects are important for people. So children might be affected by adverse childhood experiences, but then they might go on to experience very, very adverse effects as adults as well. So domestic abuse, incarceration and survival sex work, most commonly for women. Also now it's more common for people who have problem drug use to be re-traumatised in a number of ways. Prison is one way, and incarceration, a criminal justice approach, you could argue, and it has been evidenced. Sanctions and negative personal sanctions actually disrupt people's ability, one, to come for help, and two, to be able to leverage out family and friend supports. So they actually go under the radar and are harder for us as health service providers, social service providers, and friends and family members to actually bring back. So it's important to recognise that services must be very conscious of not re-traumatising, and our policy must be really careful not to re-traumatise people. Actually, people witnessing fatal and non-fatal overdoses is prevalent now in Scotland. So while we talked about small number, actually the impact is huge. And we would say it's very much a priority, a public policy a priority to resolve. Thank you.
Thank you for that. Thank you, Hugh. Can I just come to trying to identify some of the trends within problematic drug use and some of the trends within drug-related deaths? Now, I don't know who it was touched on the over 35s. You might want to refer to that again. But in the written evidence, we've also seen that there's been an increase in drug-related deaths among females, and maybe that's something you want to touch on. And I think it was you, Dr. McAuley, mentioned the increased prevalence of injecting cocaine, which I think is something we've identified particularly as a problem in Glasgow. So are these the main trends that we're seeing in problem drug use just now, or is there anything that we've missed? Or just talk us through what your views about what we're having, and we'll maybe start with you, Professor Matheson, with that one.
Yes, I started, and I mentioned to you, obviously we have this older cohort. There is an element of that. People are ageing because the drug-related deaths have increased in the older age group. The average age of a drug-related death has gone up. So that indicates a cohort type effect. And it ties in with our the health issues and the comorbidities that go along with ageing and premature ageing. So
yes.
Comorbidity, okay. Yeah, comorbidities. I'm talking about other illnesses, respiratory disease, circulatory disease, chronic pain, which people can be getting prescribed for, depression. So people can be being prescribed many medications and self-medicating as well, and that's important to highlight here, because benzodiazepines are they're more evident more recently in the drug-related deaths, and benzodiazepines are used as a sedative and also to help sleep. And we know from interviews that and work on older women who have had drug-related deaths, or older women who are at risk, that they like their benzodiazepines and they're harder to get prescribed, so they may buy them on the street. So these are kind of factors that may well play in. Self-medicating by buying street drugs because they know that in their environments that's not unusual to them, alongside prescribed medication to cope with all the other health issues that are going on.
No, absolutely.
And maybe address some of the issues around female increase.
Yeah, absolutely. And I just want to kind of add to what Professor Matheson has said about the ageing phenomenon. So that's partly related to the fact that we see an overall decline in self-reported drug use over time, and particularly fewer young people injecting drug use. So that's a success story in many ways that we see. But it does mean the existing population of people who inject drugs, we see this ageing phenomenon. But I just want to add, I think, my point of view from the piece of work that we did about women who die from drug-related deaths is that we need to understand ageing in quite a nuanced way. We think about ageing, we maybe think about inevitable age-related decline that can't be fended off. But actually what we were seeing was premature ageing due to life circumstances, this increased prevalence of treatable physical and mental health conditions. Age is a proxy for kind of other changes in life circumstances, like increasing social isolation, bereavements in social networks. And so I think when we talk about ageing, we absolutely want to emphasise that there's still many points for intervention. It's not about inevitable age-related decline. Age is also a proxy for these other forces. I also just want to add that it's not just about people ageing now, it's also maybe about being a particular age at a particular point in time. So there's evidence from NHS Health Scotland of this cohort effect, which is about this phenomenon of being a particular age at a particular stage in history. And what they found was that the people who are dying now, predominantly of drug-related deaths, were men, young men from deprived areas who came of age during the 1980s. So that's predominantly who we see the drug-related deaths occurring among. And so it's about being at a particular stage of your life at a particular point in history with all the surrounding social and economic conditions that are happening there. I'd be happy to expand on the female drug-related deaths.
Let me just leave that just now because I'm keen to get a few other views around the panel if there's anybody else that wants to contribute.
Yeah, just a point about trends. So we do see some key differences in trends over the last few years. So the shift in cocaine has been one of the most major trends we've seen, particularly in West Central Scotland at the moment. There's been a huge shift towards the injection of cocaine over the last few years. So we've seen that playing out in two key ways. One, that we've found that to be the main driver of the HIV outbreak, which is occurring among people who inject drugs in Glasgow city centre at the moment. We also see a massive increase in cocaine-related deaths within the death statistics. So that massive shift towards powder cocaine injecting is played out in both the harms and the death statistics. We've also seen, it's been mentioned, the change in benzodiazepine use. So benzodiazepines were always present in drug-related deaths, but their involvement was always capped at almost a very certain level, because it was largely related to a diazepam market, whether prescribed or illicit. But that street benzodiazepine market has changed massively in the last few years towards drugs such as atizolam or alprazolam, which are much more toxic benzodiazepines. They often 10 times as stronger as the diazepam that people would be used to be taking. They're often marketed to look like diazepam tablets, so they'll look the same, they'll smell the same, they'll be branded the exact same as diazepam tablets. So people are often taking these medications on the street unknowingly, talking about taking not in ones and twos, but talking about taking them in handfuls. So they're taking these drugs on top of their normal level of heroin, alcohol, methadone or whatever, putting people much more at toxic risk of overdose, and that has really been played out in statistics over the last few years. We've seen a massive jump in the involvement of benzodiazepines in drug-related deaths to over the 50% mark. The one other thing I would like to add in terms of prescribed medications is in relation to gabapentinoids. We've seen a huge increase in the involvement of gabapentinoids in drug-related deaths over the last couple of years, and again that's potentially related to the changes in diazepam prescribing, where people are seeking alternatives to take drugs to enhance the effects of their opiates, their heroin or their methadone.
Right. I know you're keen to come in there, Professor Matheson, is that?
Yeah, there's a couple of relevant points that I just want to make in relation to the trends and why older people that I did mention earlier. One is around isolation, social isolation, and many older drug users are living alone actually now. They are often, that's a deliberate choice to try and get away from things. So social isolation plays into this, and people are maybe more likely to take risks, and if they do, there's less emergency services and things like naloxone, which is a very useful antidote but can't be used if you're overdosing on your own. So that's one thing. And the other thing is trauma and the role of trauma in risk-taking, and maybe taking slightly more risks or being a bit more ambivalent about whether you actually do live or die when you're taking a substance.
Quickly then.
So it's just to say that in addition to the points that have just been made by Andrew, it's important to say that some service responses around fears of prescribing benzodiazepines have led to physicians taking people off prescribed medications. And so I've spoken to people where that's happened as part of some of the committee work that I do, and they've told me that their GP is no longer able to prescribe, and then they've been forced to go and ascertain the street and impure and illicit benzodiazepines, and talking about the recovery, which has been substantial, maybe years and years worth of recovery. They're also HIV positive, and they'll be on other forms of drugs, and all of that recovery and all of that stability for them and their friends and family, because if they were caught buying illicit drugs, they would be involved in the criminal justice. So it feels like sometimes service responses, whether wittingly or unwittingly, can exacerbate harms around pushing people into street drug use.
Right. We'll maybe move on to Mr. Tommy Shepherd.
Well, it's continuing on the theme. Really, it's just to explore more about the drivers at play that that lead people to take drugs in the first place, and in particular the drivers that make it that end up with it being problematic. We've talked about mental health, we've talked about poverty, trauma, and I guess in this sort of environment, we're all very much cocooned from some of the horrors that people experience in their daily lives. But we're all MPs, we all do surgeries, and we all have an inkling into some of the levels of despair and desperation that some people face. So it's not a big leap, for me anyway, I don't know about colleagues, it's not a big leap to understand why people would self-medicate and try something to get out of a situation that they're in. What I'm keen to explore is why for some people does that become problematic and for others it doesn't. Put it another way, if we could get rid of poverty and inequality, and if everybody could afford to have access to quality-controlled drugs and stimulants, would we still have the type of problem we have, or not? So how much of this is to do with society and how much of it is to do with drugs?
I think it's clear that poverty and deprivation are the main structural drivers of problem drug use in Scotland. The evidence is overwhelming in relation to that. So if you can control the poverty and inequality side of it, or if you can narrow the inequality gap, then you'll certainly go a long way to addressing that. Obviously that takes much larger forces to impact on that, and impacting on power, income, wealth, housing, employment. But these are the structural forces that created the problem drug use cohort, if you like, in the first place. And these are fundamentally the things that will address it in the future.
So we might come to the Portugal approach a bit later, but their whole system approach was not only to decriminalise drugs, so that's possession and use, but also to put in place welfare reforms. So they brought in not only expanded harm reduction and treatment, but an administrative response and minimum wage. So they basically reformed the system around humanity, around pragmatism, and around participation. And those are things that they've now been able to track for 15 years. So we have some evidence that by doing that, and there's evidence that suggests that it was largely, or in part, it's hard to pull apart the separate pieces, didn't increase use, and actually has led to reductions in use across the board. Not only problem drug use, but also use. It's not actually expanded use. So what we can see is enhancing the kinds of supports, social and economic supports, can go some way towards alleviating not necessarily drug use and experimentation, but problem drug use, because people are no longer excluded from society. The major thing that the Portuguese proponents and advocates now say 15 years later is the impact was on stigma, that people now felt that they had a voice to be able to raise their own expression of needs and fully participate in society. So there's a connection not only about welfare reform and protection of social and economic rights and human rights, but also about participatory processes.
Tommy?
Well, just before you come in, can I throw something else into the mix? I mean, to what extent is prohibition itself a driver? In the sense that if organised crime controls the price structure, what you have to pay for it, so they're very expensive. So if you're in poverty, that's a problem. They also control the supply, what you actually get. So I've read in places with people, that means that they deliberately develop products with addictive properties so that people will keep coming back for more. And of course, there's the whole, because it's illicit, the method of drug consumption itself, whether it be injection or whatever, becomes problematic. I'm asking genuinely, are those factors at play in Scotland, and is there any with Portugal or anywhere else? Can you point to comparisons where there's evidence for prohibition itself being part of the problem?
That is a tricky question. Have you got a good answer, Andy?
Well, I think the UK largely adopts a prohibition-based policy structure. Drug use is criminalised in the UK, and part of the reason we are here is because that policy, rightly or wrongly, drug-related harm just now is very significant in Scotland, and it's within the context of a prohibitionist criminalisation-based policy. So that narrative allows people to take drugs in a way that is hidden. So people are often doing it in a way that they are worried that they may get in contact with police, which often engages them in illicit behaviour, whether it's with organised crime, whether it's other levels of crime. People are often then punished for their drug use, end up in the prison system, which again exacerbates their risk for a whole host of other things and continuing their drug use as well. A lot of the prevention mechanisms we've put in place to try and prevent the harm related to drugs, whether it's things such as needle and syringe exchange. A good example of that is that people interviewed as part of the HIV outbreak in Glasgow reported that they were unwilling to carry fresh equipment on them about the streets in case they were stopped by the police and sent for further charges in relation to that. So people were then reusing their equipment or sharing their equipment, putting them at risk of other drug-related harm. So this wider context of prohibition and criminalisation in the UK at the moment, there's certainly concrete evidence that it's contributing to harm in that way.
Just to add to that, expand on exactly what Andy said about the local experience in Glasgow. Certainly as part of the work that we did on public injecting, we found that the act of public injecting, so in closes, in alleyways, in car parks and so forth, was partly because people were coming into Glasgow where the drug markets were to buy their drugs, and they're very reluctant to travel in possession of drugs. So they were injecting them very, very close to where they were buying them in the local drug markets. People were injecting in public because they were living in hostels or temporary accommodation because of their homelessness, and they knew that they would get kicked out of their accommodation, they would lose their housing if they were found to be using drugs in that situation. So again, people were going out and using in public places because of that. And people were rushing use in public places for fear of getting caught, and rushing use was increasing the risk of overdose. So certainly we see a broad evidence base from across the world about some of the potential harms of a criminalisation approach in terms of criminal records and the effect that has on people's lives. Stigma, which has already been alluded to, people's willingness to access harm reduction and treatment. And we very much see that playing out locally as well.
Okay, Tommy. Ross Thompson.
Thank you very much, Chair. And again, in a similar vein, I mean, the reason I asked about sort of the middle class use sort of early on is that I represent Aberdeen, and we have seen some growing issues. There's been an increase in drug-related crime in Aberdeen over the last year. So the police have recorded 194 incidents pertaining to the supply of illegal substances between April and September, compared to 172 the previous year. We've seen more reports, like in February, 2 men were in court with drugs valued up to £70,000 in their possession, and then a couple of months ago, 2 men were arrested with £1 million worth of ecstasy in their possession. So it's just to try and understand that Aberdeen is a very affluent city because of oil and gas, and we know that groups will travel up from areas like Wolverhampton and the rest of it to supply. Do you think in that context, given the discussion you've had with Mr Shepherd, that it may be slightly different, it is maybe a type of, rather than problematic, it is a different type of user, would that be right, or is that maybe totally wrong?
Yes, I live in Aberdeen. I have children of an age in their late teens, early 20s. I hear from them about drug use. It's fairly prevalent, I would say. It's what I would describe as experimental drug use, you know, and that is in the middle classes. The other thing that we do see is quite a lot of steroid use. That is something we need to prepare for in the future. And cocaine use, all of these things are definitely there in the middle classes. There's no denying it. And it may be that they're there more in the middle classes now than in the past, and it may be in time there will be a percentage of this group who will go on to have more problems. But we can't, that's not at the moment they're not emerging as problems. So the problems in terms of the health and the extreme problem of drug-related death.
The key point is the middle classes are less exposed to the factors that are more likely to lead them towards problematic drug use. The capital, as people have been calling it on the panel, whether it's income, whether it's employment, whether it's stable housing, whether it's adverse childhood experiences, they're much less exposed to those, and these are the factors that drive the people in the more deprived communities more likely into problematic use.
And also other things like the death of despair that's been written about. It's not just drug use, it's also particularly male suicide, but suicide, and the difficulty in actually sometimes discerning what's a suicide and a drug-related death because of loss of hope.
I also represent a prosperous area. I would be loath to call it middle class, but certainly, Perthshire would be classified as a relatively prosperous area, but it's also a large rural area. And what we've heard in some of the evidence that has been submitted to us, that there's a distinct issue when it comes to the rural area, whether that be service provision or further complications with isolation. And we were particularly struck by the evidence that was NHS Shetland, who told us that the characteristics of problem drug use in rural Scotland is quite pronounced and very different. Have any of you got any views about that you could help us with?
I've done some work with colleagues in Shetland on this very issue, and so I think it's more. So we've mentioned stigma in the passing, and maybe we'll come to it a bit more. But stigma is associated with being a drug user. If you live in a rural community where everybody kind of knows everybody else, and you may be trying to hide your drug use, it becomes much more difficult. You can't necessarily use treatment services because they may be too far, so you may be relying on your local GP practice, which will be small and local, and the people working in it will be your neighbours. So there's that added level of not being able to hide if you do want to hide, and so being fearful of how being judged by people who are your neighbours and you go to school with your kids, as well as as well as being your friends, and you, that judgment. So, and then there is also the issue of the cost of travel and the time to travel. So if you have to travel to a drug treatment centre, if you're in Shetland, want to travel into Lerwick, that's a day, that's a full day potentially. So, and there's cost associated with that as well, which people don't necessarily have. So those are added challenges of rural communities, not just in Shetland, but also rural Aberdeenshire also has these problems.
I think it's important to highlight that a lot of the problems we see within dense urban populated areas we do see in rural communities as well. So one of the studies we manage is the needle exchange surveillance, and we cover all of mainland Scotland, and we interview people injecting drugs as far north as Fraserburgh and as far south as Newton Stewart. We cover lots of rural communities as well as more city-based or town-based communities. So drug use at that kind of problem level is all across Scotland. It's not just concentrated in the major cities, which sometimes the narrative gives the impression of.
I want to pick up something that's come out of the evidence so far, and it's about intravenous drug use. And one of the big successes was the 80s in Edinburgh, wasn't it? Where the prevalence of HIV and the link to shared needles was dealt with effectively. One of probably the most demonstrable impacts of a public health programme. Why are we still having issues with this, with cocaine in Glasgow? I mean, we know how to deal with this now, and we've had experience with this, and it must be really worrying, the fact that we're still seeing issues to do with this 20, 30 years later.
It's remarkable that HIV has re-emerged in a country like Scotland, which has had effective prevention for over 30 years, since the Dundee and Edinburgh epidemics of the 1980s. I was part of the team that just analysed and published the data on that, and we have seen Glasgow experiencing an HIV outbreak for now. It's in its 5th year now. It's a very complex outbreak involving people with a lot of complex issues related to homelessness, a huge shift to cocaine injecting at the same time, which has really compromised a lot of the harm reduction that's already in place to try and prevent. Certainly the Health Board have been very successful in realigning their treatment services to get people onto treatment. But the dynamics of the outbreak itself require new additional responses, which have been demonstrated to be effective in other parts of the world who have experienced similar type outbreaks. I look at Vancouver being the obvious example, which had an outbreak in the 90s despite the presence of harm reduction and opiate substitution therapy there. And it was there where the drug consumption room was implemented to try and help contain the outbreak at that time. But yeah, Scotland, with its infrastructure, that there was probably a bit of complacency about HIV in terms of it being effectively prevented for so long that people had taken their eye off the ball and didn't expect it to come back, but it's come back, and it's come back in a very big way.
It's important to also say that the way that those kinds of services, so needle exchanges and also ORT, opioid replacement therapy, medically assisted treatment, there's very good guidance about how that needs to be delivered, and that's not always the case anywhere in the globe, having done quite a bit of work both in Canada and looking at global approaches to methadone maintenance treatment. But in Scotland, we need to do more around low-threshold access, making it really easy for people to get in. We also need to do much more around effectively retaining people in treatment, and by treatment I mean ORT, but also the broader elements of optimised ORT, which is psychosocial supports, counselling, work alongside families, recovery supports in the community, mutual aid, peer-led work. So we need to do more work on low-threshold access with treatment and also quality of care. Now those are global findings, but our rapid evidence review that Health Scotland led reminded us all that there's still a way to go around our treatment service delivery as well.
Jed Killen.
Good afternoon. We've heard from Scottish families affected by alcohol and drugs that online and digital marketing and purchasing has facilitated easy access to drugs, including via mobile texting and apps, websites and social media. Has the internet affected the supply and accessibility of drugs?
Well, we actually discussed this question. In the data that we see, there's no obvious impact of internet sales or availability on the market that we see. Certainly the illicit benzodiazepine market, there was a suggestion that perhaps people were using the internet to import illicit street benzos. But certainly there's been evidence recently that a lot of that production is now happening within Scotland itself. Scotland were involved in a large operation in a pill pressing plant in Paisley, I think, at the tail end of last year. So certainly a lot of the internet illicit market has been linked to the Psychoactive Substance Act, which was passed in 2016. Which took a lot of the availability of the drugs that were being imported, the so-called legal highs at the time, away from the kind of street-based vendors and potentially onto the internet market. But certainly in my work, I can't speak for the rest of the panel, but I don't see a huge impact of internet availability on the market yet. That may change over time demographically because, as we've said, the people using drugs problematic in Scotland are of a certain age. As young people come through and transition, perhaps they'll be more exposed to the internet in that way and more familiar to use it, but certainly it's not something we see at the moment.
Even on an individual basis, I think, in the evidence that Scottish families affected by alcohol and drugs gave, they said that individuals are being proactively pursued by dealers, either using mobile phone numbers which can be changed or social media accounts. So, if there's not a market, is it on an individual basis? Are you seeing anything like that?
I'm afraid it's not my area of expertise.
I think, unfortunately, I don't know that we can really add. You're probably getting, good evidence from there. It's not something that we've got particular expertise or ongoing research in, or any evidence we can kind of add to that, other than just saying we know it will be more of a problem in the future, and being prepared for that is obviously really important.
And in terms of social attitudes, does anyone have any experience of social media having an effect on social attitudes about the acceptability of drug use?
It's got the opposite effect, certainly. We do know that. We do know that media coverage can play into the stigmatisation of drug users, and so ideally you would think it could work the other way if there was some if media were to take a slightly different take on things. It could reduce stigma of people who are affected by drug use. I don't know if anybody else wants to expand or.
Yeah, no, I'm not aware of any studies that are reinforcing that point at the moment. Certainly there's a lot of evidence to suggest that print media, perhaps in the past and in the way drug users are portrayed, reinforces stigma, and there's nothing to suggest that wouldn't be played out as well within social media. I know there's a lot of work looking into guidelines for media outlets to try and follow, to try and help reduce the levels of stigma related to people who use drugs.
Ross Thompson.
Thank you very much, Chair. What would you say are the main differences between criminal justice and public health approaches to problem drug use?
Okay, I'll take that question, thank you. So in terms of criminal justice, we've already covered some of that material already. So a focus on supply and prevention, on policing and law enforcement. It doesn't address the harm specifically that we speak about today. It doesn't view the consequences of prohibition to be causing some, if not all. Some academics argue that prohibition and criminalisation cause many, if not most, of the problems, and some of the other experiments across the globe and can be learnt from in that respect. So the public health approach, to the contrary, supports the harms and harm reduction very specifically, and they actively support harm reduction. So harm reduction and public health very much go together, and many of our international and national bodies such as the WHO, the Royal Society for Public Health, the British Medical Association, the Royal College of Physicians have come out, some quite recently, very much in favour of a public health harm reduction approach to drugs, and actually starting to be much more critical about and much more see themselves really as advocates for healthcare and health treatment and the social reform that they're hoping to see. Did you want to comment on that, Emily, because you had some other points?
Well, to agree with what you've said already, I suppose as a public health professional, what I would see as the key values of public health is that it's evidence-informed, that we see... We look at the social context in which processes are taking place, and we particularly focus on tackling avoidable inequalities, and that we look at balancing benefits and risks. So, from a criminalisation point of view, public health approaches differ in that they don't preclude the use of criminal justice as a means to an end. There would still, under a public health approach, be enforcement around manufacture, supply, import. That's still likely to be important. But it's really about focusing on the risks to individuals and to communities and how those can be most effectively reduced based on the evidence. And that's about the integration of what we see in terms of effective harm reduction approaches, as well as a broad definition of recovery that sees where people are at and supports them in that journey. And I would say that the goal of public health isn't about the elimination of all risks. So we recognise that actually drug use over time has been a feature of most human societies. What we're focused on here is reducing harms, and public health is about balancing benefits and harms in a way that improves population health and reduces inequalities. So I would see a public health approach as guided by those values.
On that point of the balance, and this is just to throw this out there, you'll know the Press and Journal up in Aberdeen, there's one of the main stories today talks about the George Street part of Aberdeen, which is sort of split between my constituency and Aberdeen North. And in that particular community, the residents there and the community there, they're saying they're at a crisis point in terms of the issues associated with drug use and drug selling. They say that people have now moved out of the area. They've been calling for sort of more police prominence in the area because of the things associated with sort of antisocial behaviour and other consequences. So would something like that be mitigated with the purely public health approach, do you think, in terms of those residents of the community, or is it getting the balance right between a public health approach to help people who are maybe addicted to these substances or involved in these substances, and also the sort of that sort of public enforcement approach to help those who are dealing with issues about antisocial behaviour or anything else that comes with it? Just as a so in terms of those residents, to give them an answer, what is the
I'm not familiar with the situation in Aberdeen, so I can't comment on that case in particular. I think it comes back to my point about the fact that a public health approach doesn't preclude the use of criminal justice approaches more broadly, but in particular the distinction is about how we approach an individual who has problem drug use. So a public health approach would move away from criminalising that individual with the stigma, the criminal record, the potential impacts of prison on that person, and would very much focus on how we can help that individual in terms of treatment and harm reduction. But as I say, a public health approach wouldn't preclude, for instance, looking at the broader market, the organised groups that might be involved in the supply and that whole context. And again, just echoing the point I made earlier about societal context, which is what we're always banging on about in public health, which is about what are the drivers that have led to that situation arising in that particular locality, what are all the different factors at play, whether kind of within individuals, within communities, within the region, within society more broadly.
Across the range of government policies and approaches, how would you summarise the intention, whether that the balance between a criminal justice element and a public health element to that. I mean, I noticed I think somebody mentioned the United Nations, which describes drug-related criminal justice policies ineffective in reducing drug trafficking or addressing non-medical drug use and supply. And I suppose we're decades on from what was described as the war on drugs. I'm just trying to get a sense of where the trends are in terms of the approaches and how the criminal justice side of that is balanced against some of the more public health approaches, and what would you feel we need to do to try and get the right balance? Maybe that's one for you, Dr. McAuley.
Yeah, well, I think there is a growing consensus that the war on drugs, if you like, or the criminalisation approach, not just in the UK but in other countries, has largely failed. And there is a movement. Portugal is obviously the key example that a lot of people cite, but there is other examples. Of course, in Scotland as well, you look at cannabis legislation now, so personal possession of small amounts of cannabis are no longer punished in the same way they were before. So there's an increasing acceptance amongst kind of global leaders that the criminalisation approach hasn't worked, and it is demonstrated in the sheer levels of problematic drug use and harms we see in the UK and abroad. So that is where the public health approach offers a potential solution, which bridges some aspects of the enforcement approach, but with a much more human rights-based public health approach. It looks to reduce the risk at an individual level, but also at a community level.
So Portugal the approach was targeting problem drug users. So it was an administrative approach to people who were significantly at risk. They still have other sanctions for people who are supplying. So it's decriminalising drugs for personal use. Okay. One of the findings from the Portugal work shows that actually relationships between communities and police is actually improved. Which I think relates to one of the points that was just being made here. So it's not polar opposites, they can be in combination. And the reason why so many people look, I think, to Portugal is because they did many, many things. And they've also done some rigorous, including independent evaluations, and shared their findings very broadly. So I think each country needs to be able to feel free to adapt the learning from public health approaches to their own local problems. And create novel and innovative.
Both in the UK and in Scotland, are we getting that balance about right, or is it tilted in one way or the other yet? No, you're shaking your head, Dr. Parks.
Go for it, because I talked
I was just going to point out our prisons are full of people who have a drug problem. You know, I mean, I think that's the basic fact. Look at our prisons; they're full of people who are there for a lot of fairly petty, I don't know if that's the right term, but minor, thank you, drug offences, and they're in and out all the time, and that has a cost, of course. And Portugal, when they looked at the societal costs associated with their new programmes, it looked at prison costs, it looked at health costs, there has been an 18% reduction in costs overall to society as a result of their approach. And some people do, they're not getting off without some form of, they can't, calling it decriminalisation, it just means they don't necessarily end up in jail, but they will have something like they might need to do a community service, they may go into treatment, have a kind of link to treatment, it's an opportunity to intervene with treatment with people. So there is an intervention there, it's just not putting them in jail.
And importantly, it's voluntary, so there's no compulsory nature, and that's because I think the Portugal model was very much about reducing shame and stigma and encouraging people into treatment, and they know that punitive approaches don't do that.
Just to come in very quickly, I think you asked how we characterise the response, and I think at the moment we've seen the UK drug strategy from 2017 takes very much what I would characterise as a criminal justice approach. There's little or no mention of harm reduction for drugs within that strategy. It equates recovery quite narrowly with abstinence, and it talks about a kind of vision of a drug-free society. In Scotland, certainly the road to recovery was quite a recovery-focused strategy, as the name suggests, and quite a narrow focus on recovery. We are seeing some encouraging signals with the new drug treatment strategy, which makes positive noises about things like inequalities, about ACEs and mental health, and about diversion. but it's yet to be seen how that will actually play out in practice.
For that, Paul Matheson.
Thanks very much, panel. Apologies for being late, and apologies for also having to leave shortly to go back down into the chamber. But I'm really interested in this idea about trying to find the balance between the two, because it does seem to be one of the difficulties we're dealing with very different kinds of substances and often very different types of users, because it does seem like some of the criminalisation work on legal highs, which is obviously at the very other end of the threshold, appears to have been quite successful at reducing deaths, but certainly in terms of the very, very problematic users, certainly that I would see if I went to Glasgow at the weekend on a Saturday night out, you know, it is a very different approach that's needed. And I just wonder if sometimes in the conversations that we have around drugs, we kind of look at it as we're dealing with one big problem where everybody's the same and it needs one approach to deal with all of drugs as a whole. And actually what we need to do is be breaking it down much more into the different types of users, what's led them to their drugs use, and even actually what drugs they're using in terms of how we approach them.
I think a public health approach exactly does that.
Yeah.
It looks at the drivers of drug use at the outset, but it also looks at the potential responses to people who have got themselves at that problematic end of the spectrum. It also looks at the more community side of things, the kind of whole population, and how the public health approach can benefit not just the individuals using drugs, but perhaps the businesses or the residents in areas where public drug consumption is very visible to them as well, and looks at solutions to address that. So the public health approach is not absent from any enforcement aspect, and certainly the new Scottish drug strategy describes it as a public health approach to justice, so it very much sees the criminal justice setting as part of the solution. And that includes places like police custody, that include places like prison, that can be part of the response to helping individuals in that way.
Because I sometimes worry, I know that this inquiry is about the use and misuse of drugs, but you often end up talking very much about the use and very little about the supply. And do you think that actually if you move towards a more public health facing approach around use, that would then kind of shift the argument in terms of criminal justice back onto the suppliers? Because I suppose it's very easy to just say that the user is the criminal problem, whereas actually if you free that space up a little bit, it drives you back into looking more aggressively at the supply chain in terms of the criminality.
That's exactly what was done in Portugal. So at the same time as decriminalising the use of drugs for personal possession and investing in treatment and so forth, they also actually increased their enforcement at those higher levels of the supply chain. So again, it just illustrates that it's not mutually exclusive, and that was one of the factors that contributed to what was seen as a success in Portugal.
Just on legislation then, does reserve drugs legislation impact on the Scottish Government's ability to respond to the problem of drug use in Scotland?
It does. There's a very specific example that's come to the fore, of course, recently around safer consumption rooms, where Scotland would like to address this problem, particularly in Glasgow, around street injecting and the HIV outbreak that we've mentioned. So, the Misuse of Drugs Act from 1971, it is old, but it has something very specific in there that makes that not possible, and that is that if you work in a premises or you go to a premises where you know there are illegal drugs being used, that in itself is a criminal act. So it would make staff that would maybe be working on a supervised injecting facility, for example, they would be breaking the law. So that's a very specific example that has been a major barrier to moving forward with an intervention that's much needed.
I just want to add to that. We've seen in policy areas which have evolved to the Scottish Government, like alcohol policy and smoking, we've seen that Scotland has a history of public health innovation. So we've introduced minimum unit pricing. We were the first country in the UK to introduce the smoking ban. And I guess that illustrates the potential of devolution to respond to local need. And at the moment, we have a very clear evidence, a very compelling case of local need in the form of a safer drug consumption facility in Glasgow to address some of the individual and community harms associated with public injecting. But the Scottish Government doesn't have the levers to address that. And I think we also need to think about the reserve policy areas that we've been talking about, that impact on the drivers that we've been discussing in terms of income, wealth, socioeconomic inequality, child poverty and good work.
To directly, Hugh, please.
You supplement on that, talking Scottish Government. Monica Lennon, our health spokesman for Labour, she says that the Misuse of Drugs Act 1971 is not fit for purpose. Would you agree with that?
Yeah, it's a classification-based act. It's not based on any evidence related to harms. it's long overdue for review and renewal.
I just one as a pharmacist, I will say that it covers a lot. The Misuse of Drugs Act, it covers a lot. It's very clear for how pharmacists and prescribers manage drugs, what they have to do. It's very clear for them. It's clear to the police, and that's maybe so I think it's not necessarily problematic. So I wouldn't. So it's not the whole Misuse of Drugs Act that is the issue. A lot of that is very good in determining how drugs are managed within hospitals, pharmacies, the supply, all that kind of stuff. And so don't forget that. But there is very specific problems with it that are out of date.
Welcome to drug consumption. We've got a couple of questions, and I think Christine's first.
Thank you very much. You've touched on drug consumption rooms there. Could you tell us a little bit more about the research that has been done on whether or not they're effective?
The first drug consumption facility was actually introduced in Switzerland over 30 years ago, so we actually have 3 decades of evidence. There's now around 100 facilities in a number of countries worldwide, so France, Spain, Germany, Denmark, Canada, Australia. There'll be others that I'm forgetting. So we have lots of international examples to draw on, and some of the best evaluated of those are Canada and Australia, as well as evidence from elsewhere. So when we did the piece of work in Glasgow looking at local need, and particularly in relation to public injecting, we saw there was really good evidence for their effectiveness in the particular problems that we were seeing. And that evidence is endorsed by the Advisory Council on the Misuse of Drugs here in the UK, and also the European Monitoring Centre on Drugs and Drug Addiction. And what these facilities are able to do is they're able to reach people most at risk of drug-related harms. They're able to reduce the sharing of injecting equipment, which is the biggest risk factor for bloodborne viruses like HIV. They reduce levels of public injecting and drug-related litter, so there's really important benefits there for the local communities as well. And they actually appeared in both Canada and Sydney to improve people's uptake of treatment and improve people's access to treatment, because these aren't just a place where you inject your drugs, they also have really close links with treatment services and with wider services around housing, welfare and so forth. What was interesting was that there was no apparent increase in crime or antisocial behaviour in the vicinity of these facilities, and that public opinion actually tended to improve either the closer you were to the facility or the longer that it had been in place. And from a societal point of view also, we see in Canada and Australia that these facilities were cost-saving. So although they require quite a substantial initial investment of money, they save the health service money because of the averted bloodborne virus infections and overdoses. And those were quite conservative assumptions they used in looking at costs, actually. They didn't look at other forms of health harm, and they didn't look at other societal impacts. So that's the evidence that we see from elsewhere.
I was going to ask you about the other countries, but one of the other things I was going to ask was whether there are organisations, or whether any of the organisations in this country who deal with people who have problems with drug misuse, who I'm thinking about organisations like the Salvation Army, have they actually expressed any opinion or put forward any suggestions as to whether or not they think this could work, or if there is a halfway house or something else even further on?
So, as I think will be recorded in a number of the evidence submissions, there's actually a huge amount of professional and third sector support for these proposals in Glasgow. So from a third sector point of view, I believe the National AIDS Trust, the Hepatitis C Trust, Waverley Care, Turning Point Scotland have all lent their support to this. I'm sure there'll be others that others can chip in with. And also from a professional point of view, so they're supported by the British Medical Association, the British HIV Association. So they do have that support. And I think what's important about that is people recognise the context in Glasgow. So I've described the evidence internationally, but certainly the work that we did on the health needs assessment and Andy's work on the HIV outbreak has really demonstrated that we do have a population of people who have very complex needs, who are injecting in public, they're very either involved in the HIV outbreak or at very high risk of HIV, for whom this would offer a benefit. We did a survey in needle exchanges in the city centre, and 79% of people attending those needle exchanges would use a facility like this, and 74% of them said they would use it every day. There's also need in terms of the community benefits, in terms of the local residents and businesses that are affected by public injecting.
Just one other thing I was going to ask, just to go back to Mr Gaffney's question about the legislative framework. is what we possibly need, or what would you say to the suggestion that what we need is the UK government to make a special case for a pilot in Glasgow to look at the situation nationally, right across the UK, rather than only in Scotland?
Yeah, I would absolutely support that. I think, Andy, you wanted to come in as well?
Yeah, I mean, certainly that's what the Glasgow Health and Social Care Partnership have asked for, and that was what was requested, but which has been denied repeatedly by the Home Office. It's important to acknowledge Glasgow's case for a drug consumption room is arguably the most compelling case for a drug consumption room Europe has seen, for not just the UK. If you look at the most recent one that was opened in Paris, the case that was built on was nowhere near as compelling as Glasgow. If you think about the HIV outbreak, drug death epidemic, largest botulism outbreak Europe has ever seen, there is a whole host of reasons why Glasgow is a perfect case for the UK's first consumption. I would also like to just point to precedent for licences being granted for things that haven't done. The Home Office did grant a licence recently for drug checking services in Westminster and addiction service there. So there is precedent for the Home Office shifting the position to allow illegal drugs to be kept on site at a drug treatment service. So if Westminster can be granted a licence to innovate, surely Glasgow could be granted the same licence to do that.
Thank you. If I can pick up very quickly on your point about pilots, so we do see the benefits in other countries. We expect that those will be transferred to Glasgow, but it's important to evaluate that. And absolutely, the proposals that have been put forward include a robust evaluation framework. Actually, Andy and I have been involved and worked to plan that evaluation, and it's essentially ready to go if the facility were to be introduced. So it is important that's evaluated to make sure we see those benefits in Glasgow.
Conscious we're trying to get the best out of you all and we're running out of time quickly, so if you could just be a little bit more concise with some of your answers. Fascinating to know your evidence is. We'll get through a number of more of these questions. DG Rock.
Can I ask what you make of the UK government's arguments against consumption facilities in Glasgow, or at least one consumption facility? I mean, some of those concerns the Home Office, I think, indicated were about law enforcement, ethical quandaries for medical professionals, and the risk that users would travel long distances to use the room. What are your thoughts on those arguments?
Sure. So in terms of challenges for the police and law enforcement, so in other countries where this has been introduced, that's been addressed through very close partnership working between the police and the organisation of these facilities. So often the police are involved in the board or the leadership committee. And certainly in Glasgow, there's been very close working with Police Scotland and with Community Safety Glasgow. In terms of ethical objections from medical professionals, as I noted, the British Medical Association, the British HIV Association supports these proposals, and certainly there's a lot of local support from professionals that we've seen. Andy, did you want to know?
Your last question, I think, was about the honeypot effect, about attracting people towards the service. There's no evidence of that happening in any equivalent services worldwide, largely because people who inject drugs very territorially where they source their drugs. There's not a known kind of migration to different spots. So that's not something we expect to happen with the Glasgow facility. It would be put in place very much where the hotspot of public injecting is, in the east side of the city centre. But again, that is very much the sort of thing that we would study as part of an evaluation of the service. The one thing about police I would also mention, that there are a number of police and crime commissioners across the UK on record as supporting drug consumption rooms, thinking about people in those positions in Cleveland, Durham, the West Midlands, Wales. There are a number of people in those offices who are on record supporting not just the Glasgow facility, but similar facilities elsewhere in the UK.
What about the suggestion there would be ethical quandaries for medical professionals? Is that?
I don't see what the ethical quandary would be there. They would be providing an evidence-based intervention. They would also be ethically addressing people at a point of need, reducing people's likelihood to come to harm. So I can't see that being a barrier to being open.
Tommy Shepherd.
Can I come back to decriminalisation? We were talking about this earlier, but we have to write a report at the end of this process, which might well be the autumn before we get there. So I just wonder if I could invite you to be explicit in your advice to the committee. Based on what you know and the evidence that you've seen, would decriminalisation have a beneficial effect upon the problem in Scotland, and if so, how?
Certainly the evidence that I've seen and I'm aware of from all the work I've done makes me believe that we should be decriminalising personal drug use and possession. So yes, in response to that question, in terms of the difference that it will make, my colleagues can elaborate on that for us.
I would agree that if it's implemented as part of a whole systems approach in the way they did in Portugal, which looks at multiple fronts, including treatment and social circumstances in which people look at, I think decriminalisation can contribute to reductions in harms and should be supported.
Yeah. I would agree as well, absolutely. The evidence, I think, is very strong, but it's not just decriminalisation on its own, it is part of this treatment and care package, and joining up the drug policy with the social care policy and how that will work, that's a challenging bit, but that's where you need to be looking.
Yeah.
So what do we say then to the Home Office who say that decriminalisation would send out the wrong signal and would be seen as public policy encouraging problem drug use?
I would say to the Home Office that you could argue that there's a lot of policies in place. I've been asked this question a number of times, that whether decriminalisation or drug consumption rooms facilitate illegal behaviour. But we already have needle and syringe exchanges in every town and city all across the country, and they are there in the acknowledgement that people are getting in there to get sterile injecting equipment to go and use drugs typically purchased illicitly. They're not going to get stuff that's been prescribed by their doctor. So there's an acknowledgement already in society that people are engaged in drug use that is illicit, and we have these interventions in place to reduce levels of harm. Things like decriminalisation, drug consumption rooms are logical extensions to that harm reduction environment to change to an evolving dynamic of what drug use is like in the UK nowadays.
I would absolutely echo that, and I'd also echo the message sent out by our existing system, which is firstly that we're failing to implement evidence-based solutions which we fully expect to reduce harms among a very disadvantaged section of society. And also, as Andy's alluded to, that the classification system under the Misuse of Drugs Act doesn't actually reflect harms. And there's some evidence from work that the Royal Society of Public Health has been doing that people have very little faith in it because they see it as sending the wrong message. It's also important to note that decriminalisation, actually, as it's been implemented in places like Portugal, possession is still illegal. It's just that the sanctions are different. People aren't receiving criminal penalties in the form of imprisonment. They're receiving kind of civic or administrative penalties in the form of diversion to treatment.
Well, actually, because I wanted to ask a little bit more about Portugal, where they've decriminalised, so you don't go to jail for possession, but it's still illegal to supply and market certain substances. So does that leave the market in the control of organised crime then? Do they determine price, content, marketing, recruitment of people, of pushers and all the rest of it? Is that still all in place in Portugal? Or has the effect of decriminalisation of possession undermined all of that?
It's reduced the size of that market. It's certainly not increased the size of that market, which is a lot of what people perhaps thought the unintended consequence of decriminalisation or a more extreme form like legalisation would cause, that there would be much more people using drugs and much more people experiencing levels of harm. The evidence from Portugal is the exact opposite. There's actually fewer people using drugs at problematic levels now, and a massive reduction in levels of harm amongst those that are. So the evidence is clear that it works.
You Gaffney.
Sticking with Portugal, then, the examples, you say it's down. Has that also helped the public health outcomes of the problem drug?
Yeah, I mean, the two biggest indicators that are rolled out for Portugal, I mean, there's lots of different indicators you could point to, but the two biggest ones that are rolled out are their drug-related death rate and their HIV infection rate. Their HIV infection rate was over 50% before this policy came in. It's now less than 10%. That is a clear indication of how successful it's been for people who inject drugs. Their drug-related death rates are amongst the lowest in Europe. Now, obviously, acknowledging there are some issues of comparison with the data, but Scotland is at the top of that spectrum. Portugal is near the bottom.
A lot of the written evidence we've got And then this inquiry also says that the Scottish Government could do more with its existing powers. I think we're all very clear about the distinction of powers here, all the legal aspects of it, the things like criminalisation and legality is all reserved to Westminster, but the Scottish Government have a whole range of powers and a suite of arrangements and powers that they could refer to when they want to go ahead with any sort of policy. We know it's rights recovery, and what's the other part of their report, with respect, is the policy that's underpinning the Scottish Government's approach. Do you think the Scottish Government could do more with the powers it's got?
Kick off with that one. So it's difficult to answer. In terms of the most substantial levers that we've talked about, including socio-economic, they don't have all the levers to do so, so they don't have that taxation necessarily to do that, welfare, employment and the economy. So just wanted to preface the comments by saying that. However, the new policy is saying many of the right things. It responds to many of the things we've talked about as drivers and trends in terms of also targeting subpopulations, which I wasn't able to say earlier. There's lots of good work and lots of good developments, the National Naloxone Programme, the plans for heroin-assisted treatment, the ORT review, Staying Alive report, older drug user reports. They've commissioned a lot of the work that we've been able to speak about today. There's quality principles, the NESI work, and a commitment to the drugs research, drug-related deaths database work. However, of course, there can be more done. It's complex problems. Harm is increasing. We would say it's an emergency level requirement for policy and practice to act. It's early days with the new strategy. It was only published a few months ago in late 2018. There's plans for evaluation, which are very important to see. We don't have the action plan yet in the public domain. We're hopefully going to be working towards that. The public sector reform that was put in place to try to deliver what we were talking about in terms of community needs is still very early days in terms of health and social care partnerships and community partnership structures. I think there's a need for more inspection and quality monitoring in Scotland of all services, not just third sector services. So that's something personally I'd like to see in terms of attempts to drive up the quality that we talked about earlier, retention, quality and access that can be improved. I also think there's a need for more and better national coordination of drugs deaths reviews in Scotland. So those would be the things for me. I don't know if my colleagues want to add in.
This, what is it, the heroin treatment centre, which is to be established in Glasgow this year, is that right? And obviously the Scottish Government have the powers to put that forward. I mean, will this make any sort of difference? Is this the sort of thing that you believe the Scottish Government could do more of with the powers that's available to it?
So it's important to acknowledge that the heroin assisted treatment service that will open in Glasgow in the autumn is being driven locally by the Health Board and the Health and Social Care Partnership. It's not a Scottish Government initiative. The Scottish Government endorse what's going on there, but these services come from the ground up. They respond to local need. So there's been nothing stopping heroin-assisted treatment in the UK for as long. It can happen anywhere in the UK so long as there is local need and there's resource to fund it, because they're very intensive, expensive services. Mm-hmm. The doctors require a licence. The only change there was in 2012, where the licensing application scheme was devolved to Scotland, but it's still it's a UK-wide service.
Another thing is drug checking services. I think you mentioned it was Westminster, which I think was new to us in this committee. We knew there was obviously that facility available and it was ongoing in England. I believe Wales are doing something with this too. Is that within the powers of, well, obviously it would be if it's in England and Wales. Do you think there's a case for Scottish Government or one of the health boards to go down this route too?
So the service you mentioned is called Wedenos. I won't go through what the acronym means, but it's basically a drug testing service. So anybody in the UK can send a sample to Wedenos and it will be tested for you, and your result will be sent back to you. So for whatever purpose you want your drugs tested, whether you're a clinician, whether you're a festival goer or whatever you want to describe this service, and anybody in the UK can access this. I've been in touch with them recently ahead of coming here, and they do receive samples from Scotland. They don't receive lots of samples from Scotland, and it's not a service that I see promoted well in Scotland, whether within drug treatment services or elsewhere. So perhaps it could be promoted better in Scotland. Whether a Wedenos type service in Scotland that's more localised and more visible to people would be of benefit. Possibly yes, but I would like to see the existing service promoted better and used in that way.
There's two very good examples of harm reduction measures that can be put in place very easily, conveniently by the Scottish Government or health boards. Is these the sort of things that we should be doing more in Scotland?
We are able to do the drug checking in Scotland up until now. That was our understanding, certainly. So it's not within Scottish Government's powers. That's my understanding. Andy, correct me if I'm wrong. Some of the other things that we've just spoken about are, in next week we're having international researchers speak in a Drugs Research Network event in Dundee about lots of things around drug-related deaths, and one of those things is drug checking and drug testing. So they absolutely, in areas of British Columbia where they have a huge epidemic of drug-related deaths, they are now doing a lot of drug testing and drug checking work. Quite difficult to say. So they're going to be talking about their experiences of doing that with the Scottish audience. We've just sold out that event. There's a lot of interest across all ranges of geographic areas in Scotland to come to that. So it's very much something that we would want to learn from and to do. I don't see why we wouldn't be able to do it with the powers, if we have the powers, but my understanding is we don't.
Yeah, I mean, I think, sorry, Catriona.
I was just going to make a point really around heroin-assisted treatment and why that could be done in other parts of Scotland and why hasn't it been. And part of that is because the treatment services have been struggling to do what they're doing at a basic level, really, because there were cuts. Some of that money has now been reinstated, but they've been struggling to maintain a level of prescribing methadone and buprenorphine as fairly basics and the services that go around that. So developing a new system, a new service like heroin-assisted treatment does take a bit of effort and investment and time to get that up and running, and they haven't had the capacity to do that.
It's a very specialist service for a very small number of individuals who failed conventional therapy, so methadone, buprenorphine, multiple times, and that heroin-assisted treatment is made available to them. It's very intensive, twice a day, 7 days a week. Just back to your point about what the Scottish Government could do better, a few people have mentioned it, but treatment is one of the most protective factors against drug-related death, and treatment is within the gift of the Scottish Government, so opiate substitution therapy, whether through methadone and buprenorphine. And Scotland performs poorly in that. We only have about 40% of the problem drug use population in treatment at any given time. We perform poorly compared to our European counterparts of that, and those who are in treatment, the retention rates are poor again in comparison. So there have been numerous reviews of the OST system in Scotland over the years which haven't been able to make any specific impact in that sector, and that's something that is of immediate concern and something we should certainly be focusing on.
Yep. Okay, Tommy Shepherd.
Can I ask a supplementary on that first? Sorry, it's just so does Scotland perform poorly in comparison to the rest of the UK as well?
Well, it's interesting that this has come up through the evidence submissions. I've seen certain figures quoted in the evidence submissions. I wouldn't like to comment on that just now until I see how the different data sources, where they've come from and how they've been generated. I can only comment on the 40% Scottish figure because I know where that's come from, and I've compared that against a number of other comparable European countries, particularly the countries in Scandinavia. There has been an English figure quoted in one of the evidence submissions that I'm not familiar with, so I don't feel right to comment on that.
Just on treatment, from stuff I've read previously, I believe that part of the problem about treatment is that if there's a presumption of curing people, then you take them through a process of treatment, but the objective of it is to get them out of the system and get them out of treatment. So that's seen as a result. Whereas in other contexts, some people would argue that the longer you can keep somebody, you can keep people in treatment indefinitely, but that's going to lead to a better outcome than basically trying to send them out saying problem solved.
It's not a one-size-fits-all approach. Treatment goals should be identified by the individual who is being treated in collaboration with their clinician. It shouldn't be that abstinence is a goal for everyone, because abstinence might not be an achievable goal for everyone. Some people it's actually just stability, and there are many people who function, if I can use that crude term, in terms of employment, housing, who are on a daily OST script. They're just maybe not that visible to the public. So the treatment goal should be very much led by the individual themselves.
Okay.
Just quickly, we have been tied up for too long in Scotland and to a lesser extent in England about that argument about recovery and being abstinent compared to being on a long-term opiate treatment script. We need to move on from that. We need to accept there is very good evidence over decades now that opiate replacement treatment is effective at reducing drug use, reducing mortality, reducing criminal activity, improving social functioning. That is clear and it shouldn't be debated. And it is very much then not about focusing on abstinence, it's about getting stability in somebody's life, and hopefully that will eventually lead to abstinence, but there is a long process that may need to take place in the interim.
Covered, which is a recent paper around cycling in and out of treatment. So the rapid review that Health Scotland did showed that people were particularly vulnerable to drug-related deaths immediately leaving either treatment or absence-focused, either ORT treatment or absence-focused treatment like rehabilitation or prison. So in the 4 weeks coming out of treatment, that's one of the most vulnerable times. And also dose variability, so going up and then back down. So what you sometimes see in services is people that don't manage to cooperate or attend their appointments. If they miss their appointments, we've heard of 3 strikes and then you're out. So people then they have to go through all the high barrier stages to get back into treatment. We know that doesn't work. We should have not only easy access in, low threshold, trauma-informed care, but also easy re-entry back into services so that we don't have this dose variability which puts people at risk. So treatment is protective, but it needs to be high-quality treatment that people want to be engaged and involved with, and that doesn't have so many sort of personal sanctions that they're in and out on various doses. Treatment also needs to be optimised treatment, which is what the evidence-based guidelines states. Quite a lot of treatment isn't optimised in that way. So people are topping up on top, and that's been in the literature for decades and decades. So we know what we need to do, and we need to be doing it better.
I agree.
So the question I was supposed to ask was, it's looking at the powers to the Scottish Government and the debate about potential devolution in the future. I mean, I think everyone's said that the 71 Act is, if we put it kindly, needs reviewed. Is there, what can you tell us about the debate about whether the legislative framework for overseeing drug policy and classification and use, whether that should be devolved to the Scottish Government? Are there benefits to that, and what evidence do we have internationally of within big states of regional differentiation of policy?
It's tricky because the Misuse of Drugs Act, it doesn't just cover criminality of being in possession of small amounts of drugs. It covers so much more. It covers the whole framework around, as I mentioned earlier, around people who are about controlled drugs that are being used for pain and how those are managed and supplied. And so that is the challenge, I would say, is because at the moment it's a big piece of legislation that covers a lot, and if there was some of that, or some of that could be reviewed, or some of it could be devolved, that would be ideal.
I'd also just, I suppose, come back to that earlier point about devolution as responsive to local need. So I suppose that's the advantage. But one of the disadvantages is that you might create inequalities between different areas of the UK. And certainly, as Andy's alluded to, there's certainly other areas of the UK which might benefit from, for instance, safer drug consumption facilities, or from a review of the classification system more broadly. So devolution might lead to positive changes in Scotland, but we think we need to acknowledge that the rest of the UK is also experiencing a lot of similar problems. It, of course, would also depend on how any government was minded to use those powers.
Thank you. Gaffney.
Just on both governments, the UK and the Scottish Government, are they working together to address this drug use? Are they working together? Is it working?
It's an interesting question for us because we're not privy to that level of that level of collaboration, but we do see examples of it at either the advisory level work that we do or the research level work we do, and a good example of that is the focal point initiative. So each of the UK administrations is represented on what's called a UK focal point, and it's a joint UK public health surveillance for drugs, which is linked into the European centres in that way. So that's a lot of the work we do is public health type research, and that is a good example of that. But in terms of how the UK, Scottish governments are working day to day in this area, I certainly am not privy to how closely they are linked in that way.
Just that we have, my impression is that they're not working together. Yeah.
You don't feel you're getting the full support from either UK or Scottish, and is one better than the other?
So
that's a different question. So is the question about how much support we get in our work from the Scottish Government?
Yeah.
But certainly the Scottish Government are involved in a lot of the stuff that's been described today, whether it's evaluation of existing programmes like the National Naloxone Programme, in terms of funding that at the outset and putting an infrastructure in place to allow that, or whether it's endorsing some of the more recent innovations like the Safer Drug Consumption Facility in Glasgow. And it's helpful to have cross-party support in Scotland for those initiatives. The most obvious example would be recently the drug consumption room, and at a UK level we haven't seen the same support for that. But because of the nature of health policy being devolved in Scotland, most of our work is with the Scottish Government.
Is there a sense that there's a growing political consensus just now about the approach to drugs issues, or is there a right-left divide when it comes to criminal justice versus a health approach? I mean, what I'm beginning to sense, particularly in the work of the Scottish Parliament, there does seem to be a degree of consensus that the one approach, which is mainly round a health approach agenda, would that be right in that assessment? I'm seeing everybody shaking their heads, so I'm presuming it is. Maybe somebody could address it.
Certainly in relation to the Safer Drug Consumption Facilities, there's cross-party support across the Scottish Parliament for that. I think the extent to which that applies more broadly to the debate about criminal justice versus public health approaches, I'm not sure to what extent that debate has been had. I don't know if anyone else wants to pitch in on that.
We're intending to do a bit of joint work with our colleagues in the Health Committee in the Scottish Parliament, with some of us attending their sessions, some of them attending our sessions. So we're hoping to sort of join this up a little bit more, and if you have any advice for us about how we approach that, would be very useful. But I'm beginning to sense across the political communities that consensus is beginning to emerge, but you still see the odd little bit about, prohibition, about, like abstinence, and, it's all about criminal justices.
Of views and opinions, but there certainly seems drug use and related harm in Scotland is probably more visible now, whether it's on the streets or whether it's in the media, than it's perhaps ever been. So I think that's helped a growing consensus at political level. I would also say that there's examples from Westminster. There was a select committee last year that had cross-party support for the consumption room proposals. There's consensus in the House of Lords from all parties there for some of the things that have been put forward. So cross-party support isn't located just in Scotland. We've seen evidence of it here in London as well.
Consensual approach in this committee. So, Deirdre Brock.
Thanks, Chair. I want to ask about the way social security and welfare is currently delivered by the DWP. NHS Health Scotland said in a submission to the Work and Pensions Committee, "We are concerned that the current reserved social security policy, including low levels of benefits, freezes and cuts, delays and errors, poor quality assessments, benefit sanctions and natural migration, has undermined an already inadequate welfare safety net. Current reserved social security policy thus risks undermining policies to reduce problem drug use." Could I ask for your views on that?
Would like to applaud the work I think done by NHS Health Scotland in this area, because they've been doing a very rigorous programme of work on the relationship between welfare reform and health. So absolutely, as they say, social security is a really important determinant of health, partly because it has such a big influence on people's incomes, and that in turn influences their health, but also people's interactions with the system and the way that system works. Certainly from the work that we did on women dying from drug-related deaths and why that's increasing in recent years, actually the intersection between being female, being someone who uses drugs, was a huge vulnerability within the welfare system, because we know that austerity and welfare reform has had greater impacts upon women. And we also know, as Health Scotland has alluded to, that it had particular impacts on people who use drugs. Because they use public services, they have often precarious circumstances, needing support from benefits. So women are actually really at the intersection of those harms. And certainly the feedback, both from our professional stakeholders and from the women with lived experience themselves, was very powerful in identifying that as a potential factor in recent years in the increasing drug-related deaths seen among women.
I suppose uncertainty about finances would, I mean, you were mentioning stability and how important that was in terms of trying to get recovery. Something like that would be very much affecting people.
I'd like to point to another piece of evidence that the committee may be interested in, which is a large project on welfare conditionality, carried out by a number of universities, funded by the Economic and Social Research Council, which found that a lot of the welfare reforms in recent years have been ineffective in getting people into the labour market and progressing them, and that sanctions had been having very negative effects on health, and particularly among people with mental health and substance use problems. And in fact, in their conclusions, they felt that a lot of those sanctions were moving people further away from recovery. So I think, again, we're just speaking about consensus. I think within the academic community, within the health community, there is very much a consensus about the harmful effects that this is having on people.
It's been a fascinating session, and thank you very much. And I'll ask a little mischievous question at the end here, and just so you could help us properly with our report and recommendations. If there's one thing that you feel that we as a Westminster committee should recommend, I think it would be to the Home Office on this particular issue, what would that one thing be? And we'll start with you, Professor Matheson.
Well, I think we really, thinking of the drug-related death situation, I think we should be declaring a public health emergency. Absolutely. This isn't just a problem for Scotland, it's much more acute in Scotland, but drug-related deaths are also increasing across the UK. And I think that is the type of response we need to get an immediate, this is an emergency situation. We need to do something now. We can't wait for legislation changes several years down the line. That's going to be too late for a whole generation of people at risk.
I would echo what Catriona has said, but I'd also say, well, we've been talking a lot about the social determinants of problem drug use and the social drive